morning, everyone. Welcome to Pediatric Grand Rounds. Today's speaker is Dr. Richard Cordle. We are literally attached. The Department of Pediatric Gastroenterology, newly appointed Associate Professor of Pediatrics, VTC SOM. Dr. Cordle is a native of Virginia and received his training at UVA, WashU, and also completed part of his training in the United States Air Force base in San Antonio, Texas. Please welcome Dr. Richard Cordle.
So, does this transmit? Can you all hear me? Okay. So, no disclosures. I am going to talk about certain TPN products, and it's easier to work with them by name than it is to give you the chemical formula. So, in the past, I've given this lecture last about 6, 7, 8 years ago, and I talked more about the day-to-day management, and we're going to get into a little bit of that. But today, we're going to mostly talk about how things have changed or have been updated in these areas as it speaks to certain areas that have really made a difference when it comes to intestinal failure. That includes the TPN management, enteral feedings, managing bacterial overgrowth, and then managing central lines, working to keep infections low. And then we're just going to go over how those things have made a difference and briefly touch on some surgical interventions that have also been critical to improvement. So first we'll start off with the definition. So there's sort of two ways to think about it, because in the past, intestinal failure was synonymous with short bowel syndrome. That's what we would call. So a definition from 2006 states that it's a critical reduction in gut mass that makes it so that you're not able to support yourself with your gut alone, so you need an external supply of nutrition. However, that has expanded in 2012 to include other things. So if you have like an autoimmune enteropathy, or if you have a mucosal disorder where you can't digest, you can't get calories in, or as we see frequently, people who just, their guts don't move food for it, or they have, it hurts them, so to speak, to eat, so they can't do it. So you can think about, we used to use the term acute renal failure or chronic renal failure, and so you can kind of think about intestinal failure that way also. So if you come in and you have a gastroenteritis, and so you're transiently in intestinal failure, you can't use your gut to support yourself during those times, so that would be like an acute intestinal failure. And so you can think of intestinal failure as an umbrella with short bowel syndrome being a subset of that. However, as we go forward in this lecture, short bowel is what we're really talking about. These are neonates who have lost a significant part of their intestine. That really takes the bulk of the patients who we deal with. And while they typically are in the nursery for these problems, they go on in life and become patients on our floor and our PICU that we have to care for down the road. So we're going to go forward. So as we think about what kind of things make up intestinal failure, I mentioned this a little bit. 60%, show up? Okay. So roughly 60% or so are patients who have lost gut mass, as I was mentioning, from surgical procedures. So necrotizing enterocolitis, gastroschisis, atresia, or a volvulus. A small segment with long segment Hirschsprungs. We have about 2 or 3 in the Roanoke Valley. And the rest of these are a hodgepodge or a mixture of those things. The cost of intestinal failure is huge, so the burden of disease is incredible. These are 3 series from different centers, so Holland, Michigan, and Toronto. And as you can see, the first year is where there's significant cost, up to $250,000 during the first year at Holland, 1 year, $500,000 just for one patient, and a 5-year average of $1.5 million. Here's Canadian dollars, $330,000 in 1 year annual total care cost. So these patients consume a lot of resources, and so it's important that we continue to work on improvement in managing these kids. So what are the possibilities? Now, a lot of people in this room have seen some of the negative possibilities, and that's going to be part of this lecture. But when I first came here, we saw in 2002, it wasn't infrequent that we would have a patient who failed, we couldn't support them, and eventually went on to liver failure. So this is a patient who actually received a surgical lengthening procedure, and I haven't seen this kid in about 8, 9 years. But he walked away, and he's doing great. But an alternative is this. So a person who's been on chronic TPN, you can't advance it, and now they're in liver failure and need a liver bowel transplant. So we certainly want to avoid that and have the other. So before we go into that, so to kind of preface what's going on, what famous event, this is sort of taking a page out of Laura Jaco's lectures, what famous event transpired in the state? Good. That's why we had swing music going. So I found these color pictures. These are colorized pictures, and they kind of bring it to the center. So you can see the anguish. So what you're not seeing here is that these people are under continuous machine gun fire. This is actually an actual color picture from that time. The barriers were in the sea to prevent these people the soldiers from landing. Up on these bluffs were crossfire from Nazi gun emplacements, which had been there for years. And really, they were just like, it was like a turkey shoot. They were just picking them up off the beach as they landed. These guys had, you can see here, had these inflatable devices around their midsections. A lot of times they would hit the water. The weight from their packs would flip them backward, and they would drown. You can see the body count piling up here on the beach. And people said, what do we do? Do we go back or do we go forward? And they were saying we're dead either way. So they started, the courage from these men to go forward made all the difference. And so they had victory. And the victory was because they had planning and leadership and teamwork. And they had to bring over 150,000 troops. Here is a letter that was sent to every soldier that said, the victory is ours. Let me see. The tide has turned. The free men of the world are marching together in victory. I have full confidence in your courage, devotion to duty, and skill in battle. We will accept nothing less than full victory. So similarly, through leadership and teamwork and planning, short bowel syndrome or intestinal failure has had some victory over time. Before 1960, if you had a patient with short bowel syndrome, the surgeon would go in, open the patient up, and see a large section of bowel that was necrotic, close them back up, send them back to the nursery, and tell the family of the patients. That's it. It's kind of like filing an inoperable cancer. So it was expectant care, nothing much we could do. And then in the mid-60s, lipid emulsions became available, so now we can support them with venous nutrition. And so then success was a little bit greater. So here's one series from England in 1967 shows that 7 survived out of 24. 7 of 17 survived. So about mortality of 55 to 60%. 1972, maybe a little bit better results. And now we're starting to learn what kind of babies can we triage to do better. And we learned that the more length of the bowel they have, the more chance they have at success. So if you have less than 15 centimeters, nobody made it. And here, 15 to 38 centimeters, about 50%, and near 100% if you had over 40 centimeters. And this is with an ileocecal valve. If you don't have an ileocecal valve, no survival under 40 centimeters. This isn't the case today, but this is 1972. Here's a series from the Pediatric Intestinal Failure Consortium. This paper actually came out in 2012, but the data is from 2000 to 2004, series of 272 patients where 60 of them, or 58 of them, had died from either multi-system organ failure or while getting transplanted. So this calculates to a mortality of about 25%. And this is because even though we have now had this great intervention of lipid emulsions, keeping these people on these lipid emulsions over time actually was what was leading to their livers ultimately failing and them not making it. So in the the decade from 2000 to 2010, people started to collaborate and say, well, how can we improve the care of these patients? And so intestinal rehab centers started to sprout up. And so these are just some reports from if they worked collaboratively, if they made some changes, that leadership and teamwork I was mentioning, they could make some difference. And you can see that before they started working together, 15% enteral autonomy, which means you're off TPN at admission, and then 67% at follow-up. So quite a significant improvement. Another group in Seattle, survival was improved to 88%, and compared to the other slides, you can see that that was an improvement. Conjugated bilirubin improved, so hardly any liver involvement. So here's another slide showing it graphically. This is a center that stratified patients based on their entry bilirubin, so high, medium, or low, and then how you would do after weeks of treatment. And you can see that if you had a medium or low bilirubin in the hands of this rehab center, that you would almost completely resolve, whereas if you had high, some would resolve. So these are what they did. So they started cycling the TPN. They used ursodiol, or ursodeoxycholic acid. They limited the lipids as best they could. They maximized nutrition, and they used surgical interventions to help. And that's the theme of the rest of this lecture. And so if the total bilirubin is normalized, your mortality was 5%, but without, it was half. So getting these people off their TPN, away from that, which causes liver failure, improving their care over time can make dramatic improvements in their lives. Here's another slide also demonstrating that. This is from Canada. And so you can see these eras. So here's 1999 to 2002. That's the white bars. You can see that here's 2003 to 2005, the black bars, and then the charcoal bars or the gray bars are late. GIFT is just their name of their program. So you can see that removed from list, this is the transplant list. You can see how over time that improved. Less are being transplanted, less are dying. So what are the interventions they're doing that make a difference, and what can we do? So early and consistent feeding and feeding advancements, working on the lipids and making modifications with that, keeping them out of central line infections, helping and controlling bacterial overgrowth, and then bowel lengthening procedures. And that's sort of the theme of the rest of the talk. So this is an amazing picture. It looks like the state of Virginia, but this is new data that came out from the International Registry. This is number of pediatric transplants, intestinal, since 85. So here's 85 when they first started happening. And the color bars are just the type. So small bowel alone, multivisceral, modified multivisceral, just liver. Purple is liver and small bowel alone. But they're all kind of going up and look roughly about that mid-2004, 2005 that I was talking about, and then they drop off. So clearly, nationally and internationally, these changes are making substantial improvements. So we have a patient who has short bowel. Who can we predict that's going to get better? Who can we tell the parents, you need to be thinking about, intestinal transplant is going to be in your future or not? Be careful about what we say. And so this is a picture from 2001, keeping in mind the time, but this shows that your bowel length is relevant. So you remember that back in the 70s, if you were under 40, your chances of getting off TPN were low. But this is with 40, perhaps without even an ileocecal valve, and you can see that after that, the chances are great. Remember, this is 2001. And so another series, this is 1998, looked at 44 patients. 27 got off TPN, 17 did not. So 7 patients remained on TPN, 4 died, and 6 still were not at their treatment cutoff. And these are some of the things they looked at. This is a table looking at who was independent of TPN, who was still dependent, and was this a statistical significant issue to look at. So as we talked about, if you had a small bowel, those length that was higher, you were going to have a better chance of coming off TPN. This is the same with the percentage. These are the important things I want you to get from this. So this is the number of infections, and most of these are line infections. So as the number of line infections increase, you can see that your chances of coming off TPN worsen. And so I want you to keep that in mind. The second thing I want you to keep in mind is this. So in the first 3 months, the amount of calories that you can get into somebody, the amount of nutrition that you can get into somebody is also significant. So early feeding and progressive advancement of calories early can actually enhance someone's ability to come off TPN. So these are some advancements that have been made. Although I have another slide speaking to the opposite, having cholestasis was not necessarily statistically significant, although the trends more the other direction than you would think, actually. So this is from the consortium. So this is 2000 to 2004 data, and this shows that these are the outcomes here. So there's death, transplantation, or enteral autonomy. So 47% enteral autonomy, so it's about half. So not awesome data. So this is 27% got transplant, and 26% died. So, so as we have a patient that has intestinal failure, we now are faced with this patient's gone to the OR, they've come back. What are our goals of treatment now? We want to support, maintain their fluid and electrolytes, minimize their loss of nutrients in the intestinal tract, and then avoid complications, some of those that we've looked at. So the main complications we want to avoid are intestinal failure, associated liver disease, or cholestasis, central line infections. So significantly, after your first infection, cholestasis rose 2 weeks later. So you get that first infection, often you can see the bilirubin jump after that. So this is survival. This is 2004 data, but this shows that if you don't have cholestasis, your chances of making it with intestinal failure are excellent, but with the cholestasis, you can see that mortality over the first 5 years was dramatic. So this is what is the life of these patients? What are they dealing with to try to keep them out of these complications? So first they have their bowel resection, and then we start advancing their feedings. Then during this time frame, the gut is adapting, and we'll talk a little bit more about gut adaptation in a second. But the gut is adapting. We want to try to do things that help the gut to adapt so that they don't need to use TPN any longer. So we advance their feeds, and then we're not unable to advance. Okay, they're vomiting, they're having too much output, so they're unable to advance, so we hit a wall. So then what happens? Diarrhea develops. They develop bacterial overgrowth, which makes them unable to advance. They get an ileus, which makes them unable to advance. The ileus leads to stasis in their gut, which means to more bacterial overgrowth, which means they're having difficulty to advance. Then what happens? So now we have prolonged TPN. We have line infections. We have cholestasis, which comes, remember, line infections. 2 weeks later, cholestasis. We give them some trace minerals and some lipids to really spike the deal, liver failure, and death. So this is not what we want. So these rehab centers started looking at each of these areas. How can we make this so we don't go down this pathway? We can interrupt that. So this is the management in a slide. So we're going to talk about fluids briefly. We're going to talk about TPN management and length. We're going to talk about early initiation of advancement of feedings. And I'm going to try to use data to drive this discussion more than just talking about a how-to. So then you manage the complications of vomiting and diarrhea so that you can keep on going. You want to avoid line infections and thromboses. You want to, and then when necessary, do a bowel lengthening, which almost never is necessary but is helpful. And then there are some newer medications that are not quite FDA approved but close, which we can actually give to actually enhance adaptation. And hopefully we'll have time to go over each one of these things. Any questions so far? Yes, sir.
There's one slide you had that showed that having an ileocecal valve was not statistically significant.
Yeah.
Outcome, and I thought that was fascinating.
That's just one paper. I took a slide out because I had too many slides. Imagine that. So that it was a higher number of patients, okay. And actually ileocecal valve was statistically significant. It is important. That's just one data set. It's very important. And why is that? So the why is that is because the valve keeps bacteria from the colon and getting into the small bowel, and so you have more bacterial overgrowth when you don't do that.
And on bacterial overgrowth, how do you diagnose it? How do you know it's
We're going to get into that.
You're right there. Okay.
Yeah. Hopefully. So fluids. So they come back from the OR. You want to make sure that the whole team is involved in keeping good I's and O's, daily weights, and then being attentive to losses. So if you have an ostomy, you're losing half to three-quarter normal saline out of that, and so significant losses. You want to try to start replacing that, and it's easier initially to have your TPN going through one line and wiring in your replacement fluids, but that's not always feasible. So another thing to sort of keep remembering about sodium depletion, and this was data back from when I was younger. But this was actually from St. Louis, where I trained, and they learned that the losses from high output ostomies can be as high as 6 to 10 milliequivalents per kilo per day. So when you make TPN, and the maintenance is like 2 to 3 milliequivalents per kilo per day. So you're talking about 2 to 3 times the amount of sodium. So keep that in mind because it's going to impact how these patients gain weight and grow. So if you're having a lot of high ostomy output, think about that. Sorry, I want to go back. Yeah. So one thing you can do is you can measure urine sodium. So if your total body sodium depleted, your body's going to hold on to the sodium, so your urine sodium should be low in comparison to your K. People have said where you can measure the ostomy fluid, take it and measure the sodium on that, but the lab will never do that. I mean, it's not easily. You have to filter it and do things. It's just easier to get a urine. All right, so that's, so now we're going to start TPN. The TPN, as we mentioned, it allows us time to support them while the gut adapts. And the goals are to support them without getting complications. So we're going to talk about intestinal failure associated liver disease. It used to be called PNOLD, parenteral nutrition associated liver disease, but now because of the factors of intestinal failure, it's deeper than that. So what is the reason for the fact that these children have more incidences of liver disease than anybody else? So if I was to go out and get into a car accident and infarct my bowel as an adult and come in and lose a good deal of that, I hope I haven't predicted what's going to happen to me. But let's just say that happens. And I had a teenage girl when I was in Texas that had this problem, and she lost a good deal of her bowel afterward, but liver disease was not really a part of her host. But these babies have more incidences, so they're more prone, especially the premature ones, of getting liver disease. And we're not fully certain of all the reasons, but it has something to do with both their bile flow, how they get bile out of their liver, and then bile goes into the intestine and comes back. I'm going to show you a slide of that. So this is bile salts. They come out of the liver, go into the intestinal tract. They get changed, solubilized, and reabsorbed. This is supposed to be a gut. And so go and get reabsorbed. But some of them don't get reabsorbed. They get changed by gut bacteria. And they get changed into bad bile salts. And then they come back and they get sulfated, and that makes them less bad. So the baby has problems with sulfation, and they can't do that as well. And so they're more prone to that. And also, as I said, they don't get bile out quite as easily. So those two things conspire to make premature infants more at risk for liver disease. The bacterial overgrowth we've talked about produces, you have more bacteria in there, you're going to have more that become bad and become lipocholic. And that's going to promote more bacteria getting into the bloodstream through translocations, more central line infections, more liver disease. So it's a bad cycle. So any delay in enteral nutrition will also lead to less bile flow, less hormone release from the gallbladder, less getting the bile out of your liver. Bile is toxic to the liver. Recurrent sepsis or infections. So if you have more line infections, you're septic, you get more endotoxin release that makes you not get rid of your bile easily. Decreased bile acid pool, and then what the components of the TPN might be involved in IFOLD. So what are those components? Well, some people looked at trace elements. So copper has been looked at, and manganese in particular. And why? Because copper, as you've seen in Wilson disease, can accumulate in the liver and cause damage, and has been seen to be higher in patients who have had cholestasis. However, if you take copper completely out of their TPN. Over time, they become copper deficient, they become anemic, and have other issues related to that. So the guideline on that is a little bit less clear. So we cycle the trace elements rather than take them completely out. The same is true for manganese. Manganese should just be taken out completely, but because they are put in a packet in the TPN, we just cycle them to limit the amount that they involve. I'm going to move on. So what about macronutrients? That was micronutrients. What about macronutrients? When I was in residency, protein was thought to be the thing. And protein was reduced, and I still remember these emaciated little babies who had intestinal failure, and the people would tell us we weren't limiting their protein because clearly it's causing their TP, their liver disease, and we were actually perhaps causing harm. Excessive glucose can result in fat storage in the liver and steatosis, but lipid seems to be the problem. So here's early data from 2000. This is just 9 patients. This is in the European bilirubin scale. So I'll put this over here for you so you can see the translation. So this is a bilirubin of about 18. So 18 to, I didn't do the math here, so, about 6 or something like that, I think. And then they took lipids completely out of their TPN, and look at the change. Almost every one of them got better. So this started to make people think lipids are bad. And I'm not going to go into everything about them, but it looks like the type of lipids, the omega-6 lipids that are in soy, are a problem. So omega-6 lipids are pro-inflammatory, and whereas omega-3 are anti-inflammatory. So you want to have a better mix of omega-3 versus omega-6. So some people thought, let's try fish oil. And so fish oil, or omega-vin, is the product name, and I'm not promoting that. So was tried, and this I just put this in here to underscore why the soy lipids could be a problem, because they did this in a small series. 9 of 12 had complete resolution. Another series of 21 patients, resolution occurred faster, and these are just 2 of many papers that showed that fish oil was superior to soy in terms of improving their cholestasis. So here's another paper to look at that. So this is direct bilirubin on both of these scales. This is soy on the right and fish oil on the left. So you can see that this is time as your x-axis. And with time, your bilirubin is stagnant and then falls off almost universally. See how they're all below the normal line. And then this is your soy lipids, no improvement over time. So I mentioned this briefly. So fish oil is enriched in omega-3s, and this I don't know if you can see this, but linoleic acid and alpha-linolenic acid are essential fatty acids. And so I bring this up because omega-vin is actually, or fish oil is a little bit low in that, but they're enriched in these conditional fatty acids down here. So eicosapentaenoic acid, docosahexaenoic acid, and arachidonic acid. See that? So in fish oil, though, you're limited to only a gram per kilo per day. And you guys who spent some time in the NICU, you know that you need 2 to 3 grams per kilo per day to get adequate growth and nutrition. So there's a limit when you're using fish oil to how much fat you can give. And up until about October of last year, we couldn't use it anyway because it was not FDA approved and we couldn't get it. But now it is. But we'll talk a little bit more about that. So there are some concerns. You saw that those 2 essential fatty acids were low in fish oil, and yet they got better with their cholestasis. Here's the cost. So this is use this bottom bar. So 600 for a carton of 10, and compare this to intralipid, which is about 1/3 of that cost. So maybe, what about then, since fish oil is so expensive, it's not readily available, what about just limiting the soy base? Can we get by with just doing that? And that's what we've been working on since 2004 and 5 and making huge differences. And these are some papers that underscore that. So this is 31 infants in 2 groups, one where the lipids were kept at the standard 3 grams per kilo per day, which is using the soy emulsion, or a group where it was just a gram per kilo per day on 2 days of the week. And there were some cases of essential fatty acid deficiency in this group that was limited to 2 days a week. So this is the data. This is total bilirubin. And you can see that if you reduced the intralipid, that there's a trend downward, or if you continued at the 3 grams per kilo, your bilirubin continued to climb. And this is another picture of that, downward. For the 1 gram per kilo, stagnant or rising for your 3 gram per kilo, that's your bilirubin. Another paper from 2013 looked at a smaller number of patients. 28 patients were randomized, 3 grams per versus 1, and they had a significant reduction in their conjugated bilirubin. However, those that were reduced had weight and OFC scores that were significantly less. So there's a cost. We reduced their lipids. What have we done to their overall growth and development? So, what about, is there something that we can hybridize those two, fish oil and soy? So about 10 years ago, SMOFLIPID, same company makes all these brands, by the way, but came out with a hodgepodge. And so this says a soy, MCT, olive oil, or fish oil, and fish oil, so SMOF. So 30%, 30%, 25%, 15%. And looking over here, this is omega-6s versus omega-3s. So soy is 7 to 1, and fish oil is a complete reverse, 1 to 8. But there's this mix here, 2.5 to 1 in SMOFLIPID. Phytosterol is soy-based steroids, and these are what keep bile flow from happening. And so you want to keep those low. So that's why very good in fish oil-based mixture here in the SMOF. So this is looking at comparing essential fatty acids in each of these groups. So here's soy, here's SMOF, here's omega-vin. And we see that intralipids in SMOF have pretty decent amounts of essential fatty acids, less so fish oil, but fish oil certainly hands down has these conditional essential fatty acids here. This is looking at the cost. So SMOFLIPID is about the same as intralipid, maybe a little bit less, but you can see, you can compare the cost there. But it's kind of new, so we don't have any. SMOF is not FDA approved for children. It is for adults to be used in America. It's approved in Canada and Europe. And so this is a paper from Canada showing that in a pilot trial that it did significantly reduce your bilirubin over time. This is another slide looking at similar data showing that who needed omega-vin rescue, like their bilirubin just wouldn't respond, and so they needed to have omega-vin used in order to have them not go into liver failure. And you can see that nobody in the SMOF group and 6 in the intralipid, and that was statistically significant. And then this is data here, this right-hand slide. Gray is intralipid, blue is SMOF, and these are just bilirubin values. The higher bilirubin values, you don't see any of those in the SMOF group, some in the intralipid. So what is our guideline on this? So as of now, we don't use SMOF. We don't really use omega-vin. So as of now, when cholestasis begins, we start limiting to 1 gram per kilo per day. And we reduce to 3 days a week, or if not, at least at best 7 days a week, because we don't want them to go into essential fatty acid deficiency. We cycle their trace nutrients, trace elements. And then as the parenteral nutrition reduces, as you're able to get more and more gut use, then you want to cycle the TPN. And that means you give the body a chance to recover. And so you can go 12 to 18 hours of TPN, and that seems to also help the liver not to go into cholestasis. When it becomes available, SMOFLIPID can be used. Now, I should say something that when these patients leave Carilion and they go to home health, that's what they use. I was surprised by that, but I just learned this last year that every home health company is using SMOFLIPID, even on the kids. And I'm finding nobody there. I was wondering, I had this one boy who had 10 centimeters of gut. He lives in Bristol, and he, or that's what he had when he left the hospital when he was first born. And I thought he's certainly going to go on to transplant. And he's now age 5, and his liver is fine. He's been on SMOFLIPID this whole time. That's just one case. You can't, it's not, you can't use that. But I'm just saying that's compelling that these children are doing great when they leave after using SMOFLIPID. But it's not available yet here in America for kids. Omegavin is available now if we have a patient that needs TPN, but they're having refractory cholestasis. Okay, TPN. Any questions about TPN? Lipids. So lipids are bad. Yes, sir.
Dr. Nicholson will answer this question, but if you said SMOF not available in the U.S., how can the whole companies use it?
So it's not FDA approved for. Right. So what they do, so they're a business. So they're a business, and so it's much cheaper to have one. I'm just going to go by one type rather than buy 2 types. And since the price is the same as intralipid, we're going to do SMOF. So this is, all right, so now we're going to talk about feeding the gut and going from there. And so as soon as you cut on somebody and you take their gut out, the gut starts to adapt and to grow and change. And what you can see here is, this is actually a slide. This is a cartoon showing what the slide is showing. So you can see villus length increases, crypt depth also increased cellularity. And then the reasons that this happens are from hormones that are released into the gut that make it grow. We'll talk about that hopefully at the end. But also, it requires mineral nutrients. So if you don't feed the gut, you don't give nutrients into the gut, there's there's less adaptation. It will still do this, but you should also know that as the gut adapts, it does it like this. So this is the lumen, by the way. My hands are the lumen. So it expands in dimension also, and that's important. So what do we choose in terms of formula? So we're going to start feeding them, and it looks like breast milk is superior. I think this slide is confusing, so I tried to make it easy. So you know that breast milk has growth factors, immunoglobulin, enhances adaptation, and it shortens their time on TPN, and this slide shows that. So, so charcoal is bad. Light gray is good, and so that means less liver disease. And then how you look at this, these are just different time points. I don't know why they did it 4, 2, 6. And so you can see that if you're formula feeding, you have more bad, and you have less good. And then that's the same is true for each of these slides. So you'll see that. Okay. So what if we can't use breast milk? What kind of formula should we use? And this is not trying to enhance anybody, pick any kind of formula, but we want 2 things. We want, as they age, the more complex the nutrients are, the more adaptation develops. But when they're young, they can't absorb nutrients very well, so we need MCT oil to be enhanced because MCT oil doesn't require, it can go into the gut without full intact intestinal tract. So if we have a substantial amount of MCT oil, then that's helpful. We've also learned that if it was hydrolyzed, which means the protein is pre-digested, that there's less exposure to full intact proteins, less allergy to milk nutrients down the road. So, for example, and then also you want to look at osmolality because if you have higher osmols, then that's going to pull fluid into the gut as you go forward and have more diarrhea. So the guideline is start breast milk if you have it available, and also consider donor breast milk. If it's not available, then we use progesterone. You can see that's a high MCT count, low osmols, smells bad. Yeah, I'm not going to go there. I was going to talk about, we used to have these, well, again, we used to have these family practice residents. We had a lot of them. It was just before we had a peds residency, and these guys were trying to chug Nutramigen. They didn't make it. So Elecare has a higher MCT oil, and so we use Elecare or Neocate and we could probably also use Pyramino, dose of higher MCT content. For older children, as they age, we want to increase the complexity of the nutrients. That's going to enhance digestion, and they seem to tolerate that better, and almost seems to help them move up to the next step in terms of adaptation and improvement. So when should we start feedings? So the conventional is to fast until the ileus resolves, and then you start to feed. So in 2005, a group looked at 56 neonates, and half of them, roughly 33, were fed breast milk on the first day within 12 hours after operating. So what they would do is they'd give them a few mLs, and then they would put them on, they would clamp it, put them on stuff. They would actually check a residual after that, and then they would feed the next time. So they were doing this every 3 hours, small amount, and then they tried to see what was going to happen. So interestingly, the time to first stool, time to enteral tolerance, and TPN, all those things were statistically better than the other group. So, so if you remember back before, another slide said that if you had increased nutrients by 12 weeks, then you had less chance of, greater chance of coming off TPN. So early feeds and pushing it as best we can is encouraged. So what about continuous versus intermittent feeding? What's better? It's not one better versus the other, but this is some compelling evidence. You can see that I'm really up to date. Here's 1981. So where this data comes from. So, but you can see that continuous feeds, you have higher intake of these nutrients. But look at weight over 72 hours, 178 grams for weight gain and loss of the same amount in the intermittent. So here's another slide looking at the same concept. So this is exclusively tube-fed, so exclusively tube-fed ETF versus oral feedings versus a combined, oral and a combined with exclusively or with enteral feedings. And so this is confusing, but we're looking at their calories, lipids, proteins. And what this shows is you take the total here, subtract the black, and this is the amount of that they get. So, and then you, if it was significant, then you get a little star. So, this shows that tube feedings are greater than, exclusively tube-fed or better than oral, but the combination is perhaps even better than that. And this is another slide looking at the same thing. So black is total, lipids, protein, carbohydrates. This is oral feedings alone. And you can see that the error bars cross over quite a bit. So this isn't like slam dunk data, but you can see that it's statistically significant that they had more calories, more lipids, more protein delivered in the exclusively tube-fed or the combo. The combo may be superior because you guys have seen these patients and how they're orally aversive. So giving them a little bit of oral may be helpful, but it looks like continuous tube feedings early are better. So let's get some, let's try to get some data on that. So Hopkins developed these guidelines where they said, this is what we're going to do. First day of life, we're going to start feeding him. The first day after operation, we're going to start feeding him. We're going to advance 20 mLs every day if we can, and we're going to use a certain type of criteria for when we choose to do that. And they looked at certain outcomes like bilirubin and liver disease, and they found that they were, if they kept to their program, that they significantly dropped the bilirubin in half, and the discharge bilirubin was almost normal. Here's their algorithm, and so just to summarize it here. So we begin feeds as early as possible. If you're under 1,000 grams, then you get shoved over here, and you get a milliliter every 4 hours for 5 days, and then you jump into the top of the program. But everybody else, you start off on 20 mLs per kilo in the first day, and then you add 20 every day. And then you look for tolerance, and they look for distension, and they were measuring abdominal girth, something that we really haven't done as much, but I'm not actually advocating for that. It's just a difference. So in fact, I'm not advocating for that because I think it's inaccurate. But so ostomy output was used. They used 50 per kilo, 40 to 50 is a tolerable range. And then they looked for blood in the stool. If you had any of those things, then you were not advancing. And so then they went on and they measured things like cholestasis and stuff. I'm going to pass that. So this just looks at these graphs are easier to look at. So these are Kaplan-Meier curves looking at what their data was. And so if the light gray is if you were on their program, and these are controls from people in the same program before they instituted the guidelines. So these are historical controls. And you can see this is proportion with liver disease. and this is over time. You can see much less over time with those who are in the feeding group. And this is time to get to full calories, 50% of calories and 100%. You can see that there's a trend toward improvement with the early feeding. So the bottom line is use the gut, enhance it, try to go fast, as fast as you can, and try to tolerate some of the difficulties that we endure. And so I had a patient teach me this, and I thought there's no, this is bogus. You can think about as these patients, we're still talking about feeding, we talked about TPN, now we're talking about feeding. As they get a little bit older, a lot of times these babies are just on liquid alone, going into their gut. So they don't really eat because they're early aversive. So how do we get fiber into them? Well, you can use better fiber, and that helps. You can use pectin, and that helps. But I had a patient recently say, what about green beans? I said, okay, but I don't think it's scientific. Well, it is. So so this is actually a paper looking at that, and they used, where's my little thing? Oh, there it is. 1 jar to every 8 ounces or so. And so I had one patient just recently do this, and he's off TPN and doing great. So this is something to think about, just kind of cute. So we talked about TPN, we talked about advances in feedings. Now we're talking about lines, and I'm going to speed up. So children who have intestinal failure, as compared to anybody else who has lines, have much more infections. So we measure line infections per 1,000 catheter days. Is how they're kind of measured. So 7.8, this is old data from the 90s. So, but you can see that children who have intestinal failure are much more prone to get line infections than those who do not. And so if you have really 4 access points into a patient to give them nutrition, so you can do this way or this way, and if you lose half of those line access points, that's criteria for transplantation. So we want to preserve our lines as best we can. We want to avoid infections, and as I showed earlier, as soon as you get infections, you start getting into liver disease. So managing the line is critical. And so typically heparin is used to place into a line to keep it so it doesn't thrombose, and thrombosis are a problem. But ethanol locks have been tried over the last decade with some success. And these are just two of many papers that are out showing that this is superior. And I just, before I came, I tried to see, was there any kind of meta-analysis? And I did find something. Where did I put that, Joe, on our way up in the elevator? Oh, here it is. So, so one group looked at 2,760 patients and found that the relative risk was toward ethanol in terms of relative risk, meaning toward better. So it looks like meta-analyses also show that ethanol locks are somewhat superior. There are issues, but they're somewhat superior. You put 2 mLs of 70% ethanol into the line, and then you pull it back out when you're getting ready to use it. So you're not sousing your patient. So, so it comes out. So they much less infections over time. And just an in vitro study took lines, and then they bathed them in bacteria. I'd love to do that experiment. So they were bathing them in bacteria, and then they exposed them to ethanol, taurolidine, gentamicin, and vancomycin. And the first 2 showed that they actually prevented colonization and infections. And it also seems like ethanol works on keeping film, biofilm, out of the catheter, which is a problem for recurrent infections. So ethanol works for that. The problem with ethanol is that if you put ethanol on a line and heparin, the combo makes a clot. So it leads to thromboses, and also can perhaps lead to a line damage, which could be a problem. However, in that same meta-analysis, they did not see that. So they saw relative risk ratio for having complications was about the same. I did see some papers that showed that this newer product, taurolidine, which is taurine mixed with, it's a chemical that works to keep bacterial to come in. It works the same as ethanol, seems to have less of those complications, and it's used more in Canada. So here's your question, Don. Yes, sir.
The ethanol locks, from what I remember, and cannot be used on ports, only central lines. That's what I recall on.
Does it damage the port?
Correct. Yeah, it's contraindicated. just to mention that.
Okay. Did you all hear that? So my esteemed partner said that ethanol lux cannot be used with quartz as much or at all because it damages them.
Correct.
So Don, you're asking about bacteria overgrowth. How do we define it and diagnose it? And so I used to have a slide that showed the number of counts. You should have 1,000 to 10,000 colony or less in the small bowel. If you have more than that, you have small bowel bacterial overgrowth. So the ways to diagnose it are difficult. So you can go in and do a scope, and you can actually do a duodenal aspirate and send it to the lab. You have to have your tube that you use for aspirating that has to be completely sterile. Nothing can be contaminating that. You have to get a sample and have it be run right. And it's a challenge to get that, plus it's invasive. Second is you can do a breath test, and people do this, and you can use lactulose or glucose, and then you can give them that, and then they have to breathe into a bag. So kind of difficult to cure 6 months. So I assume, a lot of people who are a little bit more scientific use breath tests more. I just assume, just based on the physiology, that someone's having diarrhea, they're bloating, and they're cramping, that their physiology is such they're ripe to have bacterial overgrowth. And so I'm going to treat them. So they're predisposed to this, and hopefully we'll have time. We are running low. So these are some of the reasons why they have that. Consequences are it causes injury, deconjugates bile acids, and risk for infections. And bloating, cramping, diarrhea is problems. We treat it. With. I thought I had an antibiotic slide, but I guess I got removed. So this is bowel. This dilated, distended. It was a little cartoon that showed what happens that the bowel gets distended. And if this is this is the intestine. If I am squeezing and I'm like this, I squeeze fully and I can propel what's in there all the way and stretch it downstream. If I'm like this and I'm squeezing, I'm not having effective contractions. When that happens, the bacteria start to thrive in that environment. So decreasing the lumen size is important. In the past, I thought I had another slide too. Looking, what version of it? So anyway, in the past we had this procedure called the Bionic. It's still used. It's a little longitudinal intestinal lengthening and tapering. And you take the intestine. There's blood vessels on either side, and I have surgeons in the back, so they'll correct me. But you staple along in the center between the blood supply, and then you extend it like that. So you take it and you separate it and you extend it and you resew, and that would lengthen the procedure. Very technically complex and difficult, and outcomes really are dependent on experience with that. So a guy named Hung Bai Kim from Boston was in his pediatric surgery fellowship, I believe. He came up with this procedure, which is called the STEP procedure, serial transverse enteroplasty, and it's really just stapling in a transverse fashion across it. You can see they took this gut and made it longer and thinner, and then this will grow and adapt over time. I had more time to talk about that. So then there's also, can we make the gut adapt better by giving them hormones? And this is not FDA approved in children, but is in adults. It's called teduglutide. It's glucagon-like peptide 2. There's also a liraglutide, which is being looked at, which is GLP-1. And all this slide is showing is parenteral support. So if you're blue, you're teduglutide. Much less parenteral support if you've been on that. Boy, this is time of treatment, 2 years. So much less than if you were on nothing at all. And it's an injection that you take every day, and it's just showing the fentanyl hormone that goes into that. So this is another picture looking at bowel using bowel lengthening, or I should say adaptation using teduglutide. And this is control versus that, and this is the less parenteral support over time. Lastly, I wanted to talk about intestinal transplant. A lot of times I hear people say, oh, well, we'll just send them to the center, they'll get a transplant. That'll take care of it. and tell the parent that. And so this is Kaplan-Meier looking at liver transplant. So you can see that the 1-year survival for liver transplant is in the 80s to 90%, and then drops down to maybe 70 to 80% in time, depending upon your diagnosis. Okay? Here is the graph for small bowel. This is pediatric and adult data, and then these are eras. So survival gets better as you go up in time. But look at this, it flattens, though. And survival after 5 years pretty much flattens in all these groups at around 50 to 60%. So we're not talking about something that has as high of a success. And then this is graft survival, and this is patient survival over time. A little bit better, but still around 60%. So when you talk about sending a patient on, a lot of times they run into trouble. And there's these donor-specific antigens that get transmitted with the patient. So you know how with renal transplant, within years of that, you're already talking about it failing again because they have antigens that you have to match up HLA antigens. So similarly with this, they're learning that there's these donor-specific antigens that come with the graft and make it a challenge. So after about 5 years, they go into chronic rejection. They lose the graft, and then you're back to needing another one. This is a key summary slide showing all the problems in one slide. So, but we don't have time. So, are we supposed to do questions, Janie? Okay. So, you say a 3-week-old X28-weeker with bowel resection for neck develops total bilirubin of 5 and a direct of 3. The following are useful interventions. Choose all. Aren't you glad I don't make questions? Can't select out.
Minimize lipid.
So you said C?
D and E. And E. And E.
Okay. E is wrong because it has nothing to do with, you do keep I mean, indirectly it is. But we don't use it. This is a 3-week-old, nursery baby. We don't use ethanol locks. You're not going to, that's for sending a patient home. So you got it wrong, but
we're trying to prevent infection here, so prevent cholestasis.
Right.
Have a long-term view in mind.
You learned that. Next you're right in a sense. So it's not a good question. So 6-week-old boy with failures wondering his chances of coming off TPN. The following features of his history are reassuring.
A, D.
A and what? A and D. So early achievement of nutrients are helpful, and then having an ileocecal valve, despite that one paper I showed, is helpful. So in summary, leadership and teamwork over the last 50 years have taken us from expected death to improved survival, and much less patients going to intestinal transplant. Watching exposure to enterolipid has decreased the incidence of fatty liver disease. Newer fish oils or SMOF may be offering us other opportunities in the future. Early feeds that are continuous and then allowing oral intake is better with breast milk. Daily working to advance toward enteral autonomy enhances outcomes. Ethanol locks have dramatically made a difference with line infections. Treating bacterial overgrowth may reduce line infections and liver disease. Bowel lengthening procedures are available when adaptation has ended. You've reached a wall, and bacterial overgrowth has eclipsed progress in an enlarged, distended hypomodal bowel. Transplant should not be viewed as a goal. We don't have any number of questions, unfortunately. I wanted to have time, but
yeah, it looks like we're out of time for today. Thank you, Dr. Cordle.